Hi, my name is Wasif. I'm the owner and pharmacist of iCare Pharmacy, and thank you for listening to the iCare podcast. If you like what you hear, please consider subscribing. We offer free delivery all throughout Edmonton. By listening to this podcast, you agree not to use this podcast as medical advice to treat any medical condition, either for yourself or for anyone else. If you do have any specific issues, it's always best to consult your own physician or your own pharmacist for any medical conditions that you may be having. If you do have any other questions about your health or about the podcast, you are always welcome to text me as well. You can text me at 780-705-8871, and I'll be sure to get back to you. Anyways, enjoy the podcast, and thanks for dropping by. Take care and stay safe. Welcome to the iCare podcast. My name is Wasif, and we have our regular crew with us. There's Atif over there, and my wife Dodo off screen. Say hi.
Hi.
And then we have a special guest with us as well, Tracy. So Tracy, she is a pain health advocate. She's a founder and president of Help Alberta's Pain. She struggled herself with pain from a very early age. And about 6 years ago, she decided to, do something about it and become more active in the community and helping other people with pain. So she started the foundation Help Alberta's Pain. She last year in 2019, she got the award for what was the award again, Tracy? For it was for Pain Champion.
Alberta Pain Champion.
Alberta Pain Champion from the Alberta Pain Society. The way I would like to describe Tracy, and I mean this as a compliment, is she is a woman on fire. And what I mean by that is she's very passionate in regards to helping patients with chronic pain. And, it exudes, every aspect of her waking life. So she is a true champion. Basically, what Tracy does is, from my perspective, what she does is, the medical system can be hard on patients with chronic pain. So there's an aspect to it where myself, I'm a pharmacist, and we have physicians too, where, chronic pains being such a complicated issue, sometimes we also need help along with the patient in terms of navigating. So she comes in, provides that collaborative care to help the patient be able to kind of get the best care possible. So yeah, thanks so much for joining us today, Tracy.
Well, thank you for that wonderful introduction.
yeah, no worries.
I'm glad to be here.
Yeah. So the one thing, like, I will just say in regards to chronic pain in general is, like, previously I was in a different practice and we didn't really get a lot of exposure to chronic pain, or if we did, it just wasn't on my mindset. But I'm going to put my brother on the spot just because I feel like he'd probably be in the same place I was when I started. But Atif, what do you know what chronic pain is, or what would your idea of chronic pain be?
My understanding is that chronic pain refers to just like a long-term, like ongoing pain.
Right.
I don't know if that would mean like back pain or something, or like, I don't know what an example would be, but
yeah. And that, to be honest, like, that was kind of my understanding even as a pharmacist when I first started learning about chronic pain, and I didn't really understand how complicated of an issue it is. Tracy, can you kind of explain from your perspective what chronic pain is?
Yeah, absolutely. So the interesting thing is a lot of patients don't know what chronic pain is. It's interesting to run into patients who have not yet accepted that as sort of a label or diagnosis of what they're dealing with. So chronic pain is any pain that lasts for more than 3 months in a regular fashion and ongoing way. So that could be arthritis. Although a lot of people with arthritis don't say I have chronic pain.
Right.
There are immune conditions like lupus and other conditions like that can cause pain. We have genetic conditions like Ehlers-Danlos loss, and we have conditions that fall into neuropathic, like neuropathic diabetic pain, fibromyalgia, that kind of thing, as well as injuries that are not healing well. So a car accident in which the pain lasts for an extended period of time or a lifetime. In my case, it's a combination of a lot of those things. Chronic pain can be mild, so that it's just beginning to impact your quality of life or your function, but it can be severe to the point of leaving people bedridden and unable to function.
Right.
When it develops in a patient, it does become more complex to deal with. We often expect that when we have pain, we're going to take a Tylenol or an Advil, and that's going to make it go away, and then we're going to be fine. And for some people with chronic pain, taking a Tylenol and an Advil gives them the relief they need. They take it once or twice a day, and they're fine. But when it lasts longer or gets more severe than that, that's when chronic pain becomes very difficult. And one of the things that we know is that people who suffer from chronic pain tend to have a much lower quality of life, even lower quality of life than people say with diabetes or cancer, because it's a long-term thing without a definable end. We know that there's more association with missed days at work, loss of employment, financial difficulty, that kind of thing. And so overall, chronic pain has the ability to get so severe that it has that tremendous impact across the entire aspect of your life.
Yeah. And just to kind of add on to that, like what I'd add on to that, Atif, is just to say, like, when you have like a regular injury, generally you expect to be better in like 3 months or so, right? You're healed and you're kind of going up on about your day. But patients with chronic pain, they end up in a situation where their sensory neurons or what have you are highly sensitized. So things that would just be like touch or a brush or those slight, those small stimuli, which normally don't elicit a response, make the system hypersensitive. So when just on a touch, you're all of a sudden they're for something that would be like register a 0 for you, for someone with chronic pain, it could register like a 6 or 7 out of 10 in terms of pain. So that's another way that it's a little bit different. Yeah.
There's a condition called CRPS and chronic regional pain syndrome. One of the patients that we work with has it. Where it came from, they're not really sure why she has it. We can't really say for sure, but we know she does. And the pain that she experiences on a daily basis comes from everything from a breeze blowing across her skin or the clothes that she wears. And for the most part, she's bedridden. But even there, finding a sheet she can tolerate against her skin or pressure from a mattress can become a source of intense pain for her. So for her, it's an all over, all day struggle with just breathing. For me, I don't have as much of that skin sensitivity on a regular basis. It can come and go. But I do know that I have widespread pain throughout my body. And so at any given moment, I have a headache and my back hurts. It can be very individual for each person. But the one thing that runs true, and what you said is right, if you have an injury or an illness, because you can get chronic pain from, say, shingles. If you have an injury or an illness that should have healed by a certain point in time, and you have chronic pain beyond that point, and the healing has already taken place, then we're into a completely different realm. Then we're in a world of chronic pain.
Yeah. And so we kind of hear a lot about, like right now they're one of the things they talk about a lot in the news and the articles is, it was an issue even before COVID, was the whole idea of the opioid epidemic that we're in. And how is your relations, how has that changed, like the way chronic pain patients are kind of dealing with the situation they're in right now?
Well, I think first of all, when it came to addiction issues across Canada and overdose deaths, one of the things that happened is we focused a lot on doctors prescribing, and we focused on opioid medications being prescribed for pain. And tougher regulations and new guidelines came out in Alberta and across Canada regarding opioid prescribing. And the thing is, if it was that simple, we wouldn't really have an addiction issue out on the streets. There is a distinct difference between street drug use and opioid use for chronic pain. I'm not saying that sometimes people taking opioids for chronic pain don't develop an addiction, but we know that with proper care, the risk of developing an addiction is like 2.5% of patients. But with the development of those guidelines, and there was already a struggle because chronic pain is more complex, doctors didn't have resources and education, and then we add that extra judgment or bias on top, and we made a system that became really hostile for patients. So we've had patients who lose their doctor for whatever reason, and they simply can't find another one who's willing to take over their care. And it doesn't matter whether they're on opioids or not. It's just the term chronic pain and the desire not to wind up prescribing opioids, or not having to commit to that kind of complex care. And they avoid us. We've had more issues with patients facing judgment and bias, misdiagnosis of opioid use disorder in patients as a way of avoiding or reduction of prescribing. We had patients who were stable on medication, who were doing fine, and all of a sudden they're facing a 30% reduction of their medication just because the doctor is afraid of prescribing or because they misunderstood or misread, destabilizing the patient. And we've had patients going from finally back on their feet well enough to work to unable to function because their pain was out of control.
Right.
We've also run into the problem of patients who had mental health disorders along with chronic pain, finding themselves in a position where they had to choose. Are you going to get the medication for your pain or the medication for your mental health? But we won't give you both. And so with chronic pain, mental health is an important aspect of it. Keeping those two treated and under control together is important. But we literally had patients across the province who found themselves having to pick and choose between mental health and their chronic pain. So it's been tough out there, and patients have required more assistance finding doctors, pharmacists, treatment options, treatment plans, that kind of thing.
Yeah, and my wife has a question here.
I just wanted to circle back to this idea of what like chronic pain is. Would you say that mental health exacerbates it, like exacerbated in that, like when you already are suffering from, like, let's say neck injury or some sort of trauma to your body, whether it's on top of it, you have to deal with the mental health aspect. Do you think that makes it a lot worse for patients or people suffering?
Oh yeah, if you talk to any patient who's had chronic pain for a while and has been living with it, they can tell you that added stress, financial stress, relationship stress, emotional stress can increase your pain. We know that there is a correlation between anxiety and pain levels. And we also know that there is some correlation between trauma and increased risk of developing chronic pain. Now, that doesn't mean every patient with chronic pain has trauma, or every person with trauma is going to wind up with chronic pain, but we do know that there's a pretty strong correlation between the two. When mental health is neglected, chronic pain can be exacerbated, but the same can be true the other way. When you start being unable to connect with your community, you become more isolated. You're not able to function the way you are. You start judging yourself. I'm useless. I can't even look after myself. And those kind of thoughts can lead to depression and anxiety just from the chronic pain. And then you get into that sort of cycle of pain exacerbating mental health exacerbating pain, and really co-treatment. Treating the mind and the body together and the person as a whole being is the most effective way of managing pain.
So, like, a tough question for you, because I know some people may listen to what we have just talked about and they'll come to the conclusion that if that's the case, then chronic pain is just a mental situation. It's all in your head. How do you approach that type of viewpoint? Or how should I, as a pharmacist, approach that type of viewpoint?
The reality is that for many people, there is, not everyone, but for many people, there is a diagnosis of a physical illness, whether it's injury or it's illness or immune issue, that legitimately is causing the pain. Sometimes it's not easy to find, and we don't have that diagnosis yet, but there is a diagnosis justifying this. Secondly, your brain is a complicated beast. It really is. And so when you feel anxiety or depression, you release chemicals. Those chemicals react with the nerves in your brain. And though it may increase the pain that you're feeling, it's not a fake pain. It's really hurts. It is very real. And in fact, really all pain is, it's not necessarily that I stab you in the hand. It's that sensation, which really doesn't feel like much, runs up your nerves into your brain, rolls around in your brain, comes back down, back out, and then it says ow. So it doesn't matter whether it's a neuropathic pain that came because of anxiety aggravating nerve endings and telling us it hurts there, or there was an injury that isn't properly healing. It is real. And it is as physical and has as much physical impact as any other illness. So for example, your blood pressure can go up, your heart rate can go up, it can affect your breathing, it can affect the chemical balance in your brain and in your body, it can affect hormones, adrenal glands. If we have that kind of real impact on the body, then I don't think you can dismiss it as just a psych problem.
Yeah, definitely agree, 100%. And then the other, what else? Did you have something?
I just wanted to mention one more thing to you, and thanks. That was a very good way of approaching it, because I think many medical professionals don't realize that. I mean, I've been in situations where, I suffered from chronic pain in the past, and because unfortunately, I hate to say this, but being from a marginalized community, you're automatically dismissed as having anxiety. And I've seen other women, people of color, in the emergency room with severe chronic pain to the point where they couldn't even walk. I remember specifically a lady who, a hijabi, she was from Somalia, and she was in so much pain, the poor lady couldn't walk. And it was just dismissed, oh, it's just anxiety, here, take some back pain. And I'm like, clearly there was so much more going on to it. So one of the things I want, what can we stress to, emergency room doctors and other doctors, just to be more, how can we say, hey, no, you need to pay attention to this and be more compassionate? What are some things that you would advise on that? I don't know if I'm making sense, but.
No, that makes sense. And first I'd like to mention that what you're saying, what your experience was, that's not unusual, unfortunately. We do know that communities of color, ethnic backgrounds, women have more difficulty accessing care or being believed. There is still, sadly, this sort of dismissal of women expressing pain or discomfort as being somewhat hysterical or anxiety driven or something. And I have seen it. I have advocated for women of various backgrounds and watched it. And I myself, very, very Caucasian, had a heart attack, and I couldn't really advocate for myself in that moment. I was kind of busy. But not one, but two hospitals decided that I was probably drug seeking and overlooked clear symptoms of a heart attack.
That's crazy.
And it wasn't until my heart was stopping that anybody went, oh, wait, this is a problem. So that bias that you're talking about is a serious problem throughout the medical community. And it's something that we're advocating hard on. And the answer to emergency room doctors, to any doctor, to any medical professional, bias has never worked. Yeah. When we were wrestling with HIV, to begin with, nobody wanted to touch them. The belief was it was a gay man's cancer. And it spread and it got worse, and people died horrible deaths. But when we moved past that bias to recognize that this is an illness, this is a virus, and treat people with more respect and dignity, we began to find ways to better manage it, treat it, and care for the people who have it. The same is true with cancer. There was a time when people wouldn't want anybody to know they had the cancer because it seemed to be some judgment upon themselves. Mental health. How many people refuse to seek mental health treatment because of bias leading to other social problems that we're struggling to deal with? We need to set the bias away. We need to look at people as individuals, and we need to begin to call it out where we see it, because we're not going to get ahead. And right now, there are at least 25% of all Canadians suffer from chronic pain. There are a lot of us out there. It's not something that we are going to get a handle on, and we're not going to do a better job of managing as long as we refuse to see it, address it, and deal with it.
Mm-hmm.
And like speak on a little bit of Tracy's experience there. Like they actually, it's okay. I hope it's okay. I'm speaking on this, Tracy, but they actually, she was having a heart attack and they sent her home.
Yeah, I remember Tracy, I was in the pharmacy with you when you were telling us about that.
Yeah.
Yeah. That was insane. I can't believe you had to go through that. When you were telling us that story, I was just like, did that just really happen to you? You were clearly having a heart attack. Like, how is it, like, these people go to school for 20 years, and the fact that it, like,
well,
it's just completely...
It's like what Tracy is saying. You have your biases, and that can kind of cloud your judgment sometimes. Yeah. I think, Atif, you were going to say something earlier?
Yeah, so, and correct me if I recall incorrectly. I think I believe you said that if with proper care, one will not get addicted to opioids. Did you say that before?
Yeah, research shows that about 2.5% of patients who receive opioid therapy and have proper management of their pain don't develop an addiction.
Sorry, I just want to know what proper management would mean. Like,
well, ongoing care with their physician, check-ins, good relationship with their pharmacist, education on use, close follow-ups, and then supportive treatments. So mental health if it's needed, physical therapy if it's needed, that kind of thing. But even just like at the very bare minimum, if you have a good relationship with your doctor, if you have a good relationship with your pharmacist, and you understand the use and the risks of the medication, and you use them the way they're meant to be used, you will develop, if you take them for long enough, you will develop a physical dependency, which means if you stop taking them, you're going to go through withdrawal. But you're not going to develop an addiction where if you don't have it, you're going to go through a psychological battle to get them. In other words, chronic pain patients use an opioid to function better in their lives, whereas addiction uses an opioid to avoid functioning in life. And so as long as we monitor that and make sure that slide doesn't happen, the risk of addiction is still fairly low.
Yeah, and to speak on that a little bit, is in regards to like the patients I have, like I would say like 99% of them, just because nothing is 100, but 99% of them don't want to be on opioids. They would not want to be on it if they could help it. But the issue is they don't take it, and then their pain goes through the roof. So they're taking it for treatment, not for any other reasons.
And they don't want to be on it because of the stigma attached to it, or?
No, they just don't want, if you don't need to be on a medication, no reason to be on it. And yeah, some people do feel like, it's, opioids are hard on the system and that sort of thing. And they'd rather not be on it if they could help it, but it's just unfortunately the hand they've been dealt, right? But speaking on that,
and frankly, the stigma is also an issue. I know that being an advocate and being as educated as I am, I'm still a chronic pain patient. And I know that I have made medical decisions to accept or not accept treatment that have been influenced by my fear of that stigma. And I have got other patients who would like, and this is an important part. This is really important. I have a patient who would really like to come off of the opioids. They've been on them for a long period of time. They think maybe they might not need as much or need it anymore, but they're not sure. They're not sure because you can't tell. The problem is, number one, if you have trouble accessing care, and if you know that when the pain gets that bad, that is the thing that's going to help, but you know that if you give it up, you may never be able to find somebody to supportively help you do it again, that'll affect your decision for coming off. And lastly, because of that physical dependency, when we come off, we need to taper down, and it needs to be handled in a controlled, educated fashion with support of a doctor and pharmacist. And unfortunately, there are a lot of doctors out there that really don't understand that process well. And so a patient tries to reduce, and instead we make them sick and we torture them. Pretty soon they're resistant to reducing.
Yeah, and I'd also add on to like just the general topic here is that like some patients, because of if they have difficulty in terms of access of care in regards to their physician being able to work with them in regards to their management, whether it's opioids or otherwise, if they don't get that care, I've seen patients that do turn to the street and are using more street drugs in that situation. And that's where it can kind of lead to addiction, because they're kind of, that's where it kind of goes off the rails and it's not proper care anymore, because they're not getting the help that they kind of gave up on the medical system, and they're just kind of doing whatever they need to do to try to help manage their pain. They're just kind of at their, you only go that route when you're at the end of your rope. You know?
Right.
Yeah, and so during
and the interesting thing is that for a long time, oh, sorry, I was just going to say, for a long time, the belief from the system was that patients turned to the street because they had an addiction. But the reality is we have patients that turn to the street because they require help and can't find it. And then on the street, without that regulation and without that control and without a regulated medication, so they could be getting whatever dose out there, they develop an addiction. But they also are at risk of dying from overdose the very first time that they do that.
Yeah.
So it's a catch-22 there.
Yeah. And I was just gonna say, like, in terms of just during COVID and chronic pain management, I think because people are not as active as they were previously, and as keeping active and that sort of thing is very important in terms of chronic pain management. But we run into a situation where patients are requesting refills early or more often, just because they're not getting just because of their situation and not being able to take care of themselves as well as they would if COVID wasn't around. So how as a pharmacist would you say is the best way for me to handle that situation?
So when your doctor prescribes medication, he tells you how he wants you to take it. So often, not always, but often there is a daily dose, something that you're taking to regulate it on a daily time, and then another medication option or different pills or the same ones in a different dose or whatever, that is your breakthrough medication. And usually that's designed so that if you have a flare above normal or pain above normal, you can take it. And we get into the habit of knowing when we need it and when we don't. And you're right, during COVID, we've had patients that can't get to other treatments that they rely on, like physical therapy, injections of steroids and pain blockers and things like that. And so their pain needs have changed. We know that anxiety and stress from COVID is going to impact us. Isolation is going to impact us. That is going to change how patients are handling their pain and managing their pain. And quite frankly, there's the odd time mistakes happen. You take an extra one here or there. The first time you're having an early refill because you ran out, maybe a conversation. Look, this is how we take them, and this is why. But if something's going wrong, you need to have that conversation with your doctor. If it's not working, have a conversation with your doctor, because opioids aren't always the solution. Sometimes the solution for that is connection with mental health so that we can deal with the anxiety and stress. Sometimes it's finding a resource that encourages more motion even though we're stuck in the house. And sometimes it requires an increase or short-term adjustment of medication to manage whatever's going on. But that's the moment where we need to build a good pharmacist-patient-doctor relationship, right, so that we can have those conversations early before it becomes a regular pattern of just taking it because I feel I need it on my own. Then it becomes a question. Then doctors worry, they get stressed. Pharmacists get worried and they get stressed. Is this a use disorder developing? What is going wrong here? So I encourage patients, and I encourage pharmacists and doctors to encourage patients, have a conversation. If you start recognizing that your pain's going up and that your need for that medication is going up, have a conversation before you increase yourself.
Yeah, and I think when it comes to helping manage your pain, I think, the most important thing, like you said, is having that open relationship with your pharmacist as well as your doctor. And, and all three kind of have to be on the same page, and, assume that, the default should be that, we're coming from a place of trust and we all want, the patient to get better. That should be like the number one goal for everyone involved. Yeah.
Absolutely. And the thing is, patients, I know that we live in fear, and I know that there's going to be patients who watch this, and when I say have that conversation with your doctor, they're rolling their eyes and going, oh, I wish, because it is a really difficult conversation, and some don't feel terribly supported. The funny thing is that if our professionals work with us to build that relationship right off the bat and build that communication right off the bat, those aren't as difficult of conversations. Patients feel more supported. And then it gives us the opportunity to create a better treatment plan that will have more benefits for the patient in the long run. And a perfect example, like this has just happened this week. One of the patients that we've been dealing with has been doing worse and worse, and her function is going down, things are getting worse. And in sitting down and talking openly with her nurse practitioner and her doctor, it became evident she's not sleeping. Without the extra exercise, with the stress of COVID, the lack of any kind of concept of time or day, she's not sleeping very well. And sleep, or lack thereof, can make pain worse. And the first step that they took was managing sleep better. It didn't require an increase in opioid, and her overall well-being has been looked after.
Yeah. So, that's very important to have those relationships, and so where can like the conversation with you has been very enlightening. So we appreciate you coming on today. Where if people want to reach out, and there are some people who are kind of in a situation where they do need more help, and what's the best way to kind of reach out to you, Tracy?
Well, you can find us at helpalbertaspain.com.
Okay.
Or email us at helpalbertaspain@gmail.com.
Yeah.
And through our website, there are links to contact us, and we get back to people as quickly as we can. When we're helping patients, we'll start off by helping with, we have a support group running that's online, so people can do that safely. We have social media access for community connection. We will work one-on-one with a patient who is struggling. We offer mediation. So if the doctor-patient relationship has broken down, we will help try to mediate it. And we will help patients find connection or contact with resources, or what resources to look for in their area if they need it. So there's a lot that sometimes we can do, and often the most powerful thing that we can do is say you're not alone. Because I know that a lot of people with chronic pain feel very alone in this process and very isolated. And it seems like the most powerful word that we have is you're not alone anymore.
Oh yeah, 100%, especially now, right?
100%, because the thing is, I think a lot of people with chronic pain and trauma that make their chronic pain even worse, some of them do isolate themselves because of the judgment and the stigma attached to it. And like you said, the biggest thing you could say to someone is like, you're not alone, we're here to support you, and just offer that compassion. Like that makes such a huge difference. I know that when I was going through it, like at the beginning, I had friends who judged me, who said it was like all in my head. Thank God they're not in my life anymore. But then like when my family doctor and, had afterwards I had a good care system, my husband and my sister and everyone, they're like, no, this stuff is real. It just became so much more easier to manage and then therefore heal. And I don't think people understand that. Like, I don't know. I think once you have, don't tell someone, no, we don't agree. Don't try to control their narrative, if you've never gone through chronic pain.
Yeah.
If someone's telling you I'm in chronic pain, severe pain, don't dismiss them, until you know what it's like, until people know what it's like to go through it and really experience it. Then it's the sad part is that's when they get the empathy. But even if you've never had it before, if you've never experienced it, just be empathetic and say, oh my God, what can we do to help you?
Yeah, 100%.
Don't dismiss them. It's like the worst thing you can do for anybody.
That's the gaslighting.
That is so gaslighting in every possible way. So
Yeah.
Well, and one of the things about chronic pain is that many of us don't look sick. And if you see me on the good day out on the street or in the store, you probably wouldn't identify me as a chronic pain patient. Mm-hmm. What you don't see, and the part that they don't see, is what happens when I can't get out of the house, when I am unable to get out of bed. They don't see the morning, that first hour and a half in the morning in which just moving my legs is incredibly painful. And so when people pass that judgment and they tell you, well, toughen up, or you just got to grit your teeth through it. Well, that's pretty easy to say if you don't see how bad it gets. Ask the person who loves us, who has to watch us in that pain. I bet you they have something else to say about it.
Yeah, Atif, you're going to say?
Yeah, so I have some friends online, and I talk with them, and I'm not going to give any names or anything, but she's also complained quite a bit about having like chronic pain. Every day when she gets up in the morning, her husband has to help her just to like get her pants on. Takes like an hour and a half to like put it on by herself, so she needs help to do it. So I can relate in that way as far as like someone else having that kind of experience. Just
Yeah,
get up in the morning.
Yeah, that's how it can have like such a huge impact on quality of life. Actually, like most people, like as painful as it is, most people just want to be able to do just regular tasks like do the dishes and just help out, play with the kids and those sort of things, right? And chronic pain takes that away. Yeah. So yeah.
Your friend that suffers that way, she probably feels weakened, and she probably feels a little helpless because she needs help with things.
Right. Yeah.
I'm a chronic pain patient, but then I started working with chronic pain patients. One thing that I have learned, and one thing that I believe absolutely, and that is it takes an awful lot of grit and an awful lot of strength to keep getting out of bed when you have chronic pain. It takes a lot of personal pride and strength to keep trying to find a solution and not give up. And it takes some interpersonal strength to face the world over and over again and say, this is who I am and this is what I deal with, when you know that there will be some of that judgment. And yet chronic pain patients do this all the time and every day and never give themselves credit for the fact that they got through that day, they got through that moment, and they just kept on trucking. And it makes me incredibly proud to be a chronic pain patient, to be honest with you.
Yeah.
For sure. Yeah. So yeah, thanks again for joining us, Tracy. It was we learned a lot, and yeah, it was enlightening, and yeah, we really appreciate it. Thank you so much.
Thank you, Tracy. You're
Okay,
so
thank you.
awesome.
See you.
See you.
All right. Bye-bye, guys.
Bye.
Bye.
Thanks again for listening to the iCare podcast. Again, my name is Wasa from iCare Pharmacy, where we provide free delivery all throughout Edmonton. If you have any questions about your health, the podcast, or our delivery service, you can text me at 780-705-8871. Take care, and thanks again for dropping by.